Well, thank you for the introduction. Dr. Berger, first of all, thank you for having me here in Berlin, which is a very nice city. I've been here many times, especially for the Berlinale, and maybe next year again, but another opportunity. I'm a pediatric cardiac surgeon, and I work in 2 hospitals, in Leiden in the Netherlands, where we do mainly the pediatric population, and in Amsterdam, where we do mainly GUCH, the adult congenital population, and that's a growing population, what we see throughout the years. I was asked to talk about long-term implications after a repair of AVSD, especially focusing on myocardium. There's very little to find about myocardium specific for AVSD, on pulmonary hypertension, and on quality of life. It's very difficult to find data only specific for the AVSD population. So I decided to give you an overview of what was going on and what is going on, and the results, survival, and reoperations. This is a paper from our own data, where we published more than 30 years experience with AVSD, and you can see that the mean age at AVSD repair, all kinds of AVSD, really has decreased throughout the years. In the 70s until mid-80s, it was still over 5 years average age, and now it's about half a year for the whole group of all AVSDs. And at the same time, when age goes down, mortality also decreases importantly. And you can see that here, because the in-hospital mortality has decreased from 13% for the period earlier than 1996 to 3% since 1996. And when we specifically look to the group of complete AVSD, this drop was even more important, from 20 to 3%. And we are not the only institution where we experience this increasing survival. This is a paper from the Society of Thoracic Surgery, the Congenital Heart Surgery database, and this is a paper what was published 2 years ago. And here you see they have almost 2,400 patients with repair of complete AVSD in the period from 2008 till 2011, and the average mortality is 3%. Nevertheless, when you look to the weight of these patients, which you can see here, the discharge mortality is still very much dependent on the weight at operation, because you see it here, when the weight is around 3 kilos, and even more so when it is less than 2.5 kilos, mortality is 15%, and it goes down with 3.5, 4 kilos. So that's still a risk factor in complete AVSD, although the average mortality has decreased a lot. And this is a very interesting paper. This is a paper from Norway, from the group of Harald Lindberg, also a cardiac surgeon, and his associates in pediatric cardiology and in cardiology. And in Norway, like in most Scandinavian countries, they have the great advantage that all patients are, from birth to death, completely documented. Well, I don't know if it's a great advantage for all patients, but they have this documentation, so they can say exactly what happened during a lifetime, basically. And this is a paper that is not only about AVSD and the results in AVSD, but all kinds of congenital heart disease. But I just picked out this graph that's directed to the AVSD group. And they have almost 600 patients, and they subdivided the results and the survival in 4 different eras. And then you can see the first group operated in the 70s, that's the blue line. The mortality here is 30%. The second group in the 80s, it's still 20% mortality, the first mortality after operation, and then it rapidly drops down to 30%. And when we go to the 90s, it's already much better. You see here the mortality is about 10%, and then in the first decade of the year 2000 till 2011, the mortality is around 4%. So there is a lot gained in these 4 decades of our recent history. This is another paper. This is from a cohort of patients in Georgia, the state of Georgia in the States, and it's about survival probability of infants with AFSD on this side with Down syndrome and on this slide without Down syndrome. And they took the survival of all children diagnosed with AFSD, irrespective whether they were operated or not. And they found clear differences between different types of AFSD, partial AFSD, which has the best survival, not only in the non-Down group, but also in the Down group. Complete AFSD, they do a little bit worse, but still a survival which is around 75, in the beginning 80% and ending in 75%. And it's a little bit better in the group of non-Down patients. But when we go to the more complex AFSDs, including unbalanced AFSD, but also AFSD with tetralogy of Fallot, AFSD with arch problems, or multiple VSDs, we see that they really do a lot worse in both the Down and in the non-Down groups. And then when we go to the group with heterotaxy, they absolutely perform the worst of the whole group, and that's not very surprising, of course, but it's good to know that there is a stratification of different types of AFSD. And of course, this is also a historical series because it started, the data analysis started in 1979 and it ended in 2003. And that's one of the drawbacks, but also one of the good things of all these long-term follow-up studies, that they are historical studies, so you have to count the learning curves of everybody, of cardiologists, surgeons, and everybody included in the treatment of children with AFSD. This again is from our own group in Leiden, and we did not find this difference in survival between AFSD, partial AFSD or complete AFSD, or transitional AFSD or intermediate AFSD. The difference looks, it seems that there is a trend that intermediate AFSD is doing worse, but it was not significant over the years. And this is a group of over 300 patients. We started in 1975 with the gathering of the data, and this specific study ended in 2006. And this is a paper from the group of Ross Ungerleider in Portland, Oregon, published in 2007. There are 133 patients, starting in 1958 and ending, the end of this study was in 2000, and this is only about patients with partial AFSD. But nevertheless, it's interesting to see this because you can see that even for partial AFSD, the observed survival, which is this line, is much worse than the expected survival in the whole population. And when we go to the incidence of reoperation, so when we look to the freedom or the percent here on the vertical axis, percent with reoperations, you see that in the beginning the incidence of reoperation is about 10%, then it goes up to 20%, and when you come later and later, a lot of these patients need a reoperation, even when they only have a so-called partial, simple AFSD. And the conclusion of this study was that the survival rate for this relatively simple cardiac defect is lower, significantly lower than the general population, and in addition, the reoperation rate is still significant. But despite of this, after surgery and even after repeat surgery, patients, and even patients, especially patients without Down syndrome, can expect a more or less normal functional health status. This is a paper that's only about complete AFSD, which you can see here. It's about 200 patients, starting in 1974, ending in 2000. And this is from the group of Jim Tweddle in Milwaukee. And here you see they have a pretty okay survival, but also on the long run, the survival is not stable, and there is a constant, be it slow, attrition rate, which increases the mortality. And it's important because from this paper there's a conclusion drawn that the fact that there is reoperation in the future for these patients, that these reoperation incidences, that they affect in a negative way the survival of these patients. So when we look to the majority of the long-term follow-up patients, studies of AVSD patients, we see that the age at AVSD repair, all kinds of AVSD repair, has decreased enormously in the last 4 decades, enormously. At the same time, hospital and long-term survival also has increased enormously, despite the fact that these patients, or probably because of the fact that these patients were operated at a much earlier age. But this is something from the last 30, 40 years. And Down syndrome appears not to have a negative influence on cardiovascular survival. Of course, there are other problems with patients with Down syndrome that affect survival, but it's not specifically directed at cardiovascular survival. Probably the survival for partial AVSD is better than that for complete AVSD. For the in-between group of transitional or intermediate AVSD, we just don't know specifically because there is not enough study material in the literature to make any significant statements about this. So the central message, going back to this paper from Jim Tweddle from Milwaukee, looking at long-term outcomes after surgical repair of complete AVSD, one of the central messages from this paper was that reoperation after surgical repair for complete AVSD affects, in a negative sense, the long-term morbidity, of course, logical, but also long-term mortality. Then we go back again to our own experience. Over 300 patients, all AVSDs, starting in 75, ending in 2006. Well, we did not find, this is freedom from reoperation, again, we didn't find a difference between complete and partial AVSD. There was a trend towards a worse behavior, so more incidence of reoperations for the transitional group, but it was not significant. And then we will look to another study that we did several years later. Then the population was bigger, of course, 457 patients up till 2040, again including all types of AVSD, and we had 69 patients who were reoperated for several causes. And you can see this here. The main reason for reoperation was pathology of the left AV valve, usually insufficiency, sometimes combined with a little bit of obstruction. That's about 65% of the reoperated patients. Then there were residual septal defects, both ventricular septal defects and ASDs, and that counts for almost 20%, and that is something that is absolutely related to the early decades of AVSD repairs. That's something what we don't see now anymore. And then there is also a small bit important other group, patients who come back and need finally a reoperation for obstruction of the left ventricular outflow tract, and some patients who need reoperations, but many times at the same time when they were reoperated for left AV valve pathology for their right AV valve. So when we go a little bit more into detail in this specific population, we see that and that is an interesting finding, the timing to the first reoperation in months is significantly different for the complete AVSD group, the intermediate AVSD group, and the partial AVSD group. The time to the first reoperation for partial AVSD is around 6 years, and for intermediate or transitional AVSD, it's about 2 years, and for complete AVSD, it's around 1 year. And of course, you can speculate a lot about the significance of this finding, and I am not able to give you a very specific answer, but you can all imagine that there are several causes and explanations for this. Then, when we look to the Kaplan-Meier curves, this is after the first reoperation, we see a significant higher mortality when the left AV valve is replaced, usually by a mechanical prosthesis, compared to repair of this AV valve. And that's not something that was observed by all centers, but most of the centers agree that it's better for the patient to have his AV valve at reoperation repaired than replaced. And the durability of this repair of the left AV valve at the first operation, this is a number of 47 patients, is not perfect. When we look to the freedom from redo, so freedom from another reoperation, second reoperation in this case, at 10 years, it's only about 50%. So there is a constant attrition rate, and the need for reoperation, a second reoperation, or even a third or a fourth reoperation is a realistic possibility for these patients. The other group, and it's not a big group, it's about 5 to 10% in all big series. That's the group who come back for obstruction or for reoperation for obstruction of the left ventricular outflow tract. It's a very diverse group. There are different problems, of course. We all know that the LVOT in AVSD is different than in a normal heart. It's placed more anteriorly, it's longer, so there is a real risk of narrowing, and this risk can be influenced by surgery. If you put your VSD patch in not the completely right direction, if you put in a mechanical valve, you can get into problems. And you can see in this graph, which is an overview of all patients, of all our patients who were reoperated for LVOT obstruction. So some start with a first membrane, subaortic membrane resection, and they need another one. Some need a septal myectomy, because in some of these patients we have this anterolateral muscle bundle, which is abnormal and usually not found in normal hearts. But some of them end up with a Roscono operation. Here is one, and there is another one. And then the mortality, of course, increases. So it's a complex problem and has to be treated very individually. This is a very, very long-term series, and of course it's coming from the Mayo Clinics. This starts in '62, ends in 2006, and they only gathered patients with reoperations, almost 100, and only after partial AVSD repair. And there they didn't find this significant difference in survival after repair and replacement. This is just to show you that there is still some variation in these long-term series. Most of the people, however, agree that the fact that you have to replace the AV valve by usually mechanical prosthesis is not good for survival, and that's a significant difference, but in this case it was not found. And the conclusion of this paper is that, again, the most common indication for reoperation after initial repair of simple AVSD is pathology of the left AV valve, and again followed by recurrent obstruction or again new obstruction of the left ventricular outflow tract. And when a reoperation is required, this has a negative influence on overall late survival, which of course is logical. So reoperation after AVSD repair initially in childhood is common, and sometimes multiple reoperations are needed, 2, 3, even 4. And this is also true even after simple partial AVSD repair. Reoperations are usually needed for recurrent or residual insufficiency of the left AV valve, and to a lesser extent for obstruction of the left ventricular outflow tract. Reoperations do have a negative influence on all over survival, and we believe that if you have to reoperate, it's better to avoid valve replacement, and you should do your best to repair the valve. Not always possible, of course, but it's better to repair the valve than to replace it. The problem is, and that is interesting, and it was alluded to yesterday by Dr. Dietrich already, that we still don't know everything from AVSD. There are new things coming out of recent research, and I just wanted to show this to you. This was a study, several studies that were mainly done by Emeline Kalkoen, who was a PhD fellow in our hospital, and she used 4D flow MRI, streamline visualization, to compare healthy hearts with hearts after AVSD repair. And there are several interesting things that were observed from this study and could really be concluded in a significant way from this study. This is the heart of a healthy volunteer, and here you see the inflow through the mitral valve from the left atrium into the left ventricle, so it's a straight flow, it's not deviated. And on the contrary, this is one patient, but this really was true for all the patients after AVSD repair that were put into the 4D MRI protocol. The inflow is really much more lateral than here in healthy volunteers. It's going towards the posterior wall of the ventricle. And you can imagine this, because when you look to this paper, to this figure, this is an opened left ventricle of an AVSD patient. This is the superior bridging leaflet, this is the inferior bridging leaflet, and this is the mural or left lateral leaflet. When you close the cleft, which we commonly do, and of course it's open for debate, but which we commonly do, when you close the cleft, you can imagine that the anterior leaflet that you make in this way is getting restrictive, and the blood, the inflow of this AV valve is forced towards the posterior wall. We really don't know what the significance of this is, and maybe we will never know, but it's interesting to find, and maybe it will have some clinical consequences for the future. But at this moment, this is totally open for debate. And then going on from this research, they also looked to different left ventricular vortex ring formations, and these vortexes or the turbulences in the left ventricle, they help to close the AV valves, and they were really totally different from normal heart than from AVSD hearts. This is a normal inflow with, that's what they told me, I'm not an expert on this issue, a normal vortex, and this is AVSD heart with more posterior flow direction and abnormal vortices. So they found this, and this was found, and it's still open for debate, and maybe the whole issue of cleft closure comes because of this study results in another light. Dr. Brizard from Melbourne already pointed out that it's not always necessary to close this cleft, and maybe for the future, on one hand, it can be better for the patient because you don't make this anterior leaflet from the left AV valve so restrictive when you leave the cleft open or partially open. On the other hand, we know from follow-up studies that when you leave it open or you don't close it, there's a higher incidence of insufficiency. But what we many times see is that when we have to repair a left AV valve insufficiency after initial AVSD repair in childhood, and then we are talking about adult congenital patients, that it may result, because you have to do something about this anterior leaflet, in even more restriction of the anterior leaflet. And we have seen cases where you really end up easily with an obstructive left AV valve. So it's interesting and still open for debate, and maybe in the discussion we can talk a little bit more about this. Now we are facing many patients with congenital heart disease, adult patients. It was calculated in my country, in the Netherlands, there are a lot more adult patients with usually operated congenital heart disease than children with congenital heart disease, and this difference is increasing. And as surgeons, we also see that the number of operations in children is relatively stable, a little bit up, a little bit down, but didn't change significantly throughout the last 10 years. But the number of congenital adults who needed an operation, that's going up by 5% every year. So we need resources for this. And I'm really glad that the European Society of Cardiology is looking into this and providing us with guidelines, even though the level of evidence is not always as good as we are used to for coronary patients, etc., etc. So I would say that reoperation in good patients, congenital adult patients with AVSD will be a next challenge. Thank you.